Hello, my name is Meghan O'Neal, and I would like to present the Unplanned Extubation Pre- and Post-Evaluation of a Policy Change presentation. My supportive committee consists of my DMP chair, Dr. Teresa Gallicatos, my second reader, Dr. Lisa Stroyer, and my community member, Dr. Guest. Just a little bit about myself. I began my college career at Allegheny College of Maryland in Cumberland, Maryland, where I graduated with my associate's degree of science in nursing. I went on to Frostburg State University, where I obtained my Bachelor of Science in Nursing degree. In the fall of 2018, I began my graduate degree journey here at Maryville University. I will be finishing my Master's of Science in Nursing degree for family practice in December and my Doctorate of Nursing practice hopefully this month. Outside of the education world, I'm a bedside nurse nationally certified in neonatal intensive care at a Level 4 facility in the Northeastern region, as well as an adjunct faculty member in the nursing program at Allegheny College of Maryland. I wanted to start us off by introducing my doctoral project to you all. Unintended extubation is a nationally known problem for NICUs and is labeled the fourth most common adverse event. Unintended extubation can be traumatic for this fragile population and could lead to further lung damage, bleeding, or even cardiovascular collapse. Here on the left, I have an image I felt like was an excellent visual to try and explain what the neonatal lung looks like. Babies that are admitted into the NICU have various diagnoses, but in order to need ventilator assistance for respiratory support, the normal alveoli inside of the lung are collapsed or underdeveloped. That would then require mechanical assistance, also known as the ventilator. The endotracheal tube is the tube that goes inside of the baby's trachea, providing the ventilator support. This tube can range from 2.5 to 4 millimeters in diameter. These small figures lead to little room for error. This brings me to my question. For NICU nurses, how does the one-person transfer method compared to the two-person transfer method impact unintended extubation rates over 1 year, 2019 to 2020? I developed this question through an extensive literature review. I utilized the Maryville Online Library and really focused on the CINAHL and Medline databases. In reading what felt like a little over 1,000 articles and journals, I came up with 3 main themes that seem to be present in the majority of the research. Number 1, adverse events before and after unintended extubation. Number 2, endotracheal tube securement methods and sizes. And number 3, a culture of safety through multidisciplinary action and two-person transfer method. When searching through other quality improvement and observational studies, it seemed as though the primary reason for unintended extubation included things like loose tape, patient movement, excessive secretions, which of course led to coughing or even pulling out of the ET tube, ET tube manipulation like suctioning, retaping of the ET tube, and unsupported ventilator tubing. Other factors included bedside procedures and handling, or transferring of the patient during things like kangaroo care with the parents. After identifying the adverse event, it seemed only appropriate to focus on the securement method because the research defined 2 main ways of securement, one of which being the 2 pieces of tape cut into a Y shape, and the second being a device called the NeoBar. Finally, the culture of safety through the multidisciplinary team members who provide the two-person transferring method ranked up there for my top literature review. It is without a doubt evident in majority of the research that when the staff caring for this fragile population all work together for patient care times, the rate of unintended extubation was decreased. Multidisciplinary is really the word I'd like to highlight here because although nursing is the primary caretaker, you also have respiratory therapists, nurse practitioners, physicians, physical therapists, occupational therapists, and speech therapists that are all trained in the proper handling of ventilated patients. This photo on the left I felt like was a great representation of the size of baby that we're talking about. This baby had to have been a very young gestation, which we'll discuss a little bit later. But that Butterfinger is just a general, regular sized candy bar. It's not supersized or anything like that. Here are two photographs of the securement methods that I just explained. On the left is the two pieces of tape that are cut into a Y shape that holds the ET tube into place. Then on the right is a diagram and photograph of the securement device, called the neobar. On the right here, you can see how the different sizes correlate with a color change in the device. Moving on here, the work of Faye Abdella, which can best be described through her Guide to Nursing Care, titled 21 Nursing Problems. Her patient-centered approach to care is the cornerstone of this scholarly project. Rather than focusing on the disease process, whether it be respiratory distress syndrome or extreme prematurity, each ventilated baby needs to be viewed separately. Individualized care is the future of best practice measures for all NICUs across the world. Providing seasoned nurses with many years of experience this same education as new graduates about these risks of unintended extubation, that will help to further prevent this occurrence from happening over and over again. Again, just moving forward with more project design information here, as well as the key factor of IRB approval. I received IRB approval through Maryville University first, then received it through the facility in which the project occurred. COVID made this IRB process unbelievably difficult, and I was truly unsure of whether or not my proposal and applications would even make it to the right desks because of how poor communication was. Here we are, and I'm so grateful to be past that point. Anyways, I wanted to give you my point for inclusion into this study because there are various reasons why NICU babies need to be intubated, and I wanted to focus on those babies who are ventilated for more than 12 hours, not necessarily those babies who are circumstantially intubated. I also included this diagram on the right that I really like because I feel like this allows my listeners to understand the margin of error that we discussed at the beginning of the presentation. So when measuring whether or not the ET tube is in the right place, centimeters are used. And in this photo, you can see just inside the lip of this patient is the 9.5 centimeter mark. For NICU babies, the range of intubation goes from 4.5 to about 9.5 centimeters. This seems like a long range of distance, but that's because the number is based upon the patient's weight. The smaller the baby, the less the tube is inserted, making the tiniest of babies ventilated using 4.5 centimeters of a tube. When this airway becomes dislodged, there is typically multiple nurses present, a nurse practitioner or two, or even multiple respiratory therapists. The time and effort it takes to replace the airway requires this extensive multidisciplinary effort, which ultimately is all an attempt to prevent respiratory collapse, which would lead to cardiac arrest in this population. For this next slide, I wanted to give some more specific details about the SPS bundle. This Northeastern Region NICU is a part of a larger network of NICUs from across the United States that have committed to using evidence-based practice to better the bedside care of babies. This bundle was researched and utilized in other NICUs, making it more desirable for this NICU to adopt. The key components are laid out here on this slide for you to read about. Just to recap before moving on to the results section. In this retrospective chart review, I examined not only the two securement methods that we viewed earlier, but also kangaroo care, the presence of emesis, gagging, and excessive secretions, one-person versus two-person transfers, as well as the time of day and gestational age. So kangaroo care, that's when a mother or father performs skin-to-skin time with their baby. This promotes bonding and when done correctly is beneficial for neurodevelopment as well. Unfortunately, this wonderful experience can be overshadowed by cords and wires, which include the ventilator tubing, making for a potential situation where unintended extubation would occur. So now here we have the first of three graphs that I would like to show you for my results section. The dark blue bar graph represents the pre-policy extubations, while the light blue graph represents the post-policy extubations. As you can see, this NICU staff was actually incorporating the two-person transferring and repositioning even before the policy came into place. Ineffective taping was also a major problem prior to the policy change, and when it comes to emesis, gagging, and excessive secretions, the policy change did not really change this adverse event. The category that also caught my eye was the one-person transferring method. This represented 5 unplanned extubations prior to the policy change, but clearly the staff was compliant with the changes for the most part because only 1 extubation occurred without the proper staff present in the post-time period. This results graph also shows that tasks like kangaroo care and taping were improved upon the post-policy change. This brings me to my next graph, where you can see the gestational age in which unplanned extubation occurred most often. Gestational age is how the NICU measures time and developmental needs of a premature baby. Instead of saying that a baby is 1 week old or 37 days old, the staff will gauge the needs of the baby based upon their gestational age. So if your baby is born at 24 weeks, but is now 7 days old, the staff will say that this baby is 25 weeks old. I hope this helps to clarify the importance of this graph. As you can see, the staff improved their techniques when it comes to that 31-week gestation and younger. The unsettling part of this graph is the increase in extubation that occurs in the 32-week to 42-week age range. It would be interesting for me to see in future studies if there is a correlation in the older a baby is to how frequently unplanned extubation occurs. Since there is no form of sedation used in this population, it begs the question of when does this baby really become bothered by its breathing tube? Next, I have 2 visual representations for you of the difference in size. The photo on the right in the bottom is a baby that was born at full term, 40 weeks gestation, holding the same ball that is next to the 23-week baby in the top right photo. Both babies were 1 week old in this photograph. On the left is a 23-week baby fresh after delivery, still in his plastic bag that helps to maintain his skin integrity during the resuscitation and admission process. I felt like this picture was notable to help reinforce my previous discussion of how the skin is so fragile and even the best of tape jobs will still slough off this face because of the poor skin integrity. You can see here the staff are wearing gloves, which is also in the policy for caring for this gestational age. You're not able to touch these babies at all unless you have gloves on for that first week of life for pure skin protection. This also reiterates the point of how difficult it is to properly use tape with gloves on. I'm not sure if any of you have tried it, but it's very difficult to say the least. Finally, the third graph I would like to share with you is my evaluation of time, which I have separated out into the time periods that correlate with shift work based upon bedside nursing. During the day shift, it is no surprise that there are more unintended extubations, and I say this because more multidisciplinary team members work during the day. So like your physical and occupational therapists, all of those people are touching and handling these ventilated patients. Also, it's only fair to infer that parents are also visiting and holding their baby during those daylight hours. Anybody who has worked night shift knows that there are far less touching times or even tests performed on the night shift, which is also evident in this graph. I can infer that in that 1600 to 2300 hour, most parents are visiting because it's an evening hour, and most parents do eventually have to go back to work, even if their baby is spending days in the NICU. So being able to come and spend time with their baby and hold their baby during the evening hours would of course increase the risk of the baby having an unplanned extubation. Next, I would like to give some information about the statistical side of the project. Thanks to Dr. Pauls, I was able to perform a two-tailed z-test, which is in the chi-square family of tests. This test revealed a p-value greater than the significance level, which does not indicate statistical significance. The second bullet point gives the power, which is considered medium for this project. Essentially, if you put this power into a percentage, it would mean that I have a 47% chance of showing a deviation from the null hypothesis, which in this case I did not. I feel as though the numbers I have just presented to you, that raw data, is very specific and should be able to help get the point across about how serious this problem of unplanned extubation is for NICU babies. Next, we have the discussions, implications, and recommendations slide where I would like to explain some of my thoughts. First, I believe that a taping education for bedside staff would be essential in changing the results of future studies. I believe it is also notable to say that maybe there is a different type of tape other NICUs are using, and this NICU should evaluate that and change based upon the further evidence-based practice about the successes in other NICUs. Next, it is important to reiterate that the NICU nurse is the guardian of these patients. And with that being said, future studies and policy changes need to have that understanding in mind. The feeding intervention should also be looked at considering emesis, gagging, and excessive secretions ranked most consistently in the results, no matter which month or year it was. Of course, a larger sample size would have helped my statistical tests, and a longer lengthened study could provide more accurate results, especially if it were associated with ventilator days. Determining whether or not the number of ventilator days or that gestational age makes a difference in unplanned extubation would be worth future research and study. Finally, self-reporting I felt was notable to discuss because essentially I would not have been able to perform this project without self-reporting, right? So in my study, I am depending on the staff members to accurately report these unintended extubations and understand that there is no punitive measures when self-reporting. I think all of us can safely say that in our jobs, it's not easy to basically tell on yourself for doing something wrong. Writing a safety report or form could be misunderstood as bedside staff doing something wrong, even when policy and procedures are adequately being followed. Having the safety reports reflect a more narrative response to the event could bring a better picture of what was truly happening without having a reporter bias. Because maybe the nurse says the baby was vomiting, and that is why he extubated. Then the respiratory therapist says, no, this baby was being turned the wrong way, and that is why he extubated. That multidisciplinary teamwork and understanding of how to properly care for these patients will be a testament to the success for ventilated patients. This leads me to my last bullet point there of dissemination and sustainability. Having the education be a unit-wide requirement along with competencies that occur every 3 to 6 months would be my best recommendation for patient care. Being able to continue this study to look at the trend in extubations along with the associated adverse events will help to better trend and track the data. These are handouts that are posted around the NICU for nursing reference about positioning of intubated babies. These continuing education pieces on this slide were put out prior to the completion of this study, but are an excellent way for me to show improvement following results. If any of you are in the field of neonatology, know somebody who is, or even have had a baby in the NICU, I encourage you to take a screenshot at this time so that you can view these handouts a little closer. They are an excellent form of education. At the bottom here, I have 3 links that you can click on that show short clips. They are step-by-step how-tos for taping a neobar, taping using Y-shaped pieces, and retaping an already secured ET tube. On this conclusion slide, I would like to take a minute to reflect on how important it really is to me to be obtaining this terminal degree. Nurses with advanced degrees, especially at the doctoral level, should be having conversations and monitoring the data with a manager or QI department, especially in a critical care setting. This DNP program has made me critically aware of the fact that I need to ask for data and be aware of data in order to better patient care. The QI team should not be the only people having data. That dissemination of data should be a priority for continuing education in this critical topic. Thankfully, this NICU does have a QI team that is specifically managing and discussing unplanned extubations. In the future, I would like to trend and track data for this special population to make more of an impact in the neonatal intensive care units. The start of life is so precious to me, and I am just very thankful to be able to speak to you all about this topic that is so close to my heart. Finally, I would like to thank all of you for listening to my doctoral presentation, and at this time, I'd like to welcome any questions or comments. I also would like to show you my reference page. Thanks for listening.